Okay, we're good.
Okay, I'm going to broadcast. Hi, everyone. Thank you for joining. We're going to give individuals a few more minutes to log on, and then we'll get started. So please bear with us. Hi, if you're just joining us, thank you for logging in. We are giving individuals a few minutes to log on, and then we'll go ahead and get started. So please bear with us. All right, well, in the interest of time, let's go ahead and get started. First, thank you all for joining us today. My name's Katherine Fine. I'm a genetic counselor and lead the clinical cancer services at Genome Medical. And we want to thank you for taking time out of your busy schedules for the webinar. In collaboration with Illumina, we wanted to bring to you a webinar regarding hereditary breast and ovarian cancer. And this is really in honor of International Women's Day. So for those who may not be familiar with International Women's Day, it's an annual celebration where we really celebrate the social, economic, cultural, and political achievements of women. And partly why we wanted to bring this webinar to you is because we at Genome Medical want to celebrate and encourage women to continue these achievements, in part by being proactive about your health. The objectives of today's talk are really to first provide some historical background regarding cancer risks and hereditary breast and ovarian cancer. We also want to talk about some key elements of personal and family histories that might be suggestive of hereditary breast ovarian cancer syndrome, or HBOC as we refer to it, and discuss the role of a genetics evaluation in HBOC. And on today's webinar, we have individuals and employees of Illumina from across the world. So I do want to mention we will talk towards the end of the webinar regarding how we can actually serve individuals, whether you're located in the US or whether you're located in a different country. Throughout the webinar, please feel free to ask questions. We're more than happy to answer any questions. If you are logged in at the bottom of your screen, you should see a Q&A box. That's a question and answer box where you can actually type in your question. You do have the option to do this anonymously, or you actually can leave it where all attendees would see your name. So I'll just mention that in case it matters. And we will address all questions at the end of the webinar. And if we're not able to get an exact answer for you, we will follow up with you after the webinar. But do please feel free to enter your questions at any time during the webinar. So let's start first by talking about global cancer incidence. This is important when we think about ways for us to reduce cancer risk. It's important to know what that looks like on a worldwide level. So this data is actually data presented by the International Agency for Research on Cancer. It's recent data from 2018. And when we think about new cancer diagnoses worldwide, you can see that the global cancer incidence does vary by continent, with some continents have significantly high cases and some have lower. But I think we would all agree that any case is too many. More concerning than that, however, is really the mortality of cancer. And so if we actually look at the estimated number of deaths, but for both sexes, I should say, and this does include all cancers, including non-melanoma skin cancer for all ages. You can see that about half of the cancer cases each year actually do result in a death. And I think we all would agree that this is concerning and something that we should all work towards bringing down. If we actually then separate out the types of cancers that happen on a worldwide population, the highest cancer is actually breast cancer. And that's ultimately why we also wanted to address breast and ovarian cancer today. When we think about hereditary reasons for breast cancer, many times this also includes an increased hereditary risk for ovarian cancer. So although ovarian cancer is a more rare cancer, because they can be linked in a hereditary sense, that's why we wanted to bring this webinar to you. So it's important that we realize there are actually many factors that can contribute to an individual's personal risk for cancer. It's not just hereditary risk, but there are other factors such as lifestyle factors, environmental factors, the aging process in itself, and then just chance. All of these factors, including family history and genetics, do contribute to an individual's lifetime risk for cancer. They all influence the risk, but sometimes there are factors and modifications that we may be able to make to reduce risk, and sometimes certain factors may increase risk. So if we actually separate out breast cancer risk first for women, you can see on the left-hand side Factors such as maintaining a healthy weight, exercising regularly, actually even having a pregnancy, and having that pregnancy before age 25, breastfeeding, as well as if a woman were to undergo menopause at an earlier age, are actually factors that could decrease a woman's risk for breast cancer. On the right side, you can see that some of these factors do increase the risk, and it's sort of the opposite of those factors. So obesity, a sedentary lifestyle, alcoholic drinks, exposure to radiation, aging process, and then again, sometimes hereditary factors, which we'll talk more about. Similarly, for ovarian cancer risk for women, there are various risk factors, some of which correlate with breast cancer. But again, some factors that may increase the risk other than age include having more menstrual cycles throughout one's lifetime, hormone replacement. Factors that could decrease the risk include removal of the ovaries and fallopian tubes as a means of prevention, childbearing, breastfeeding, oral contraceptive use, particularly when used for 5 years or more, or even tubal ligations. So we've been learning about genetics and hereditary influences on life and disease for a long time, and it's fascinated, obviously, both scientists and the general public. And one of the most common focused areas of research for genetics and hereditary influences of disease is, in fact, cancer, and this does include both breast and ovarian cancers. And so in order to sort of understand these influences better, I want to make sure we all understand or have a basic concept understanding of genetics. So if we think about our genomes are essentially the equivalent of our instruction book. So they're a book about us. And if we open that book, there are chapters within that book or chapters within our genome, and these really correlate with structures called chromosomes. And chromosomes, or chapters of the book, are actually made up of sentences, which are essentially the equivalent of a gene. And it's really the gene that our body uses to help us grow and develop, and can have also some medical implications sometimes. So all of our genes are actually made up of DNA. Each sentence is essentially a series of letters. The letters that make up our DNA are A, C, G, and T. And these DNA base pairs that form our genes are arranged in a specific order. And this is true from one person to the next. And sometimes changes in the order of these DNA bases can actually change the way that gene works. And it sometimes may affect the function of that gene that could lead to some sort of medical consequence. So if you think about changes to a single letter of DNA changing the way DNA works, it's very similar to how a letter in a sentence can actually change the meaning of that sentence. So if we had a sentence that said the gray cat ran down the hall, that makes complete sense. But if we simply change one letter in one word, the gray cat fan down the hall, that sentence really has no contextual meaning anymore. And so when we think about our genome and the cancer research that's been done looking at different genetic makeups of different cancers, it is true when we look at the genetic and hereditary influences on cancer cells that most of these changes in these cells are actually not hereditary. So although cancer is all genetic, it is a genetic change in a cell that's allowed that cell to grow uncontrollably into cancer. It's usually not a genetic process we inherit. So about 70 to 80% of cancer is actually what we call sporadic or acquired, something that happens either by chance or as an external factor, but not something that was inherited or is familial. About 15 to 20% of cases are familial, and this could actually be something that a family has been exposed to simultaneously in the environment. It could be something of a lifestyle that a family attributes to. It also could be hereditary, but more in the sense of potentially hereditary that has yet to be discovered. But about 5 to 10% of the time, cancers can be due to a hereditary reason that's identifiable. And that's really what we'll focus on today. But I do want to explain how this process works. So when we think about cancer in general, most cancer being sporadic, it is genetic, so mutations are actually acquired in genes over time. And again, those mutations allow those cells to grow into uncontrollable cells or cancer or a tumor. Um, the difference is sometimes an individual can actually inherit a mutation, and this could be inherited from either a mother or a father. And that mutation, an individual is not born with cancer. That mutation that they've inherited doesn't mean an individual would automatically get cancer, but it does mean that they're at a significant increased risk for cancer because they started and were born with a higher risk. So sometimes that can explain different features that we see in a family. And so when we are actually thinking about cancer in a family and we're trying to determine, is that cancer due to a hereditary predisposition, or do we feel that this is more of a sporadic acquired type of cancer, we really do care about multiple generations of the family. And we want to look for different hallmark features in a family that could be suggestive of a hereditary predisposition. So if we're actually thinking about hallmark features of HBOC, or hereditary breast ovarian cancer syndrome, some of the features that we would look for and ask a family member about is there breast cancer in the family, and at what ages was that diagnosis? So the earlier the diagnosis, the more suggestive this could be of a hereditary predisposition. And with breast cancer, we tend to think of age 45 or under as an early diagnosis. We also know that because individuals who are at a higher risk for breast cancer are also potentially at a higher risk for ovarian cancer, depending on the gene involved. Any individual diagnosed with ovarian cancer is a hallmark feature. Ovarian cancer tends to be a more rare tumor type and has a slightly higher correlation independently with a hereditary predisposition. We also know that individuals who have been diagnosed with multiple cancers, and these are typically multiple primary tumors, so not a recurrence of the same cancer. We don't think about that in the same way, but for an individual who's developed two separate independent cancers, so it could be two breast cancers that are unrelated to each other, or two separate cancers altogether. If we're seeing multiple relatives affected with cancer on the same side of the family, and this could be the same cancer or combinations of cancers, if we're seeing individuals of certain ancestries, such as those listed here, or if we're seeing rare tumor types, such as male breast cancer, pancreatic cancer, or again, ovarian cancer, these can all be hallmark features that an individual or a family may have hereditary breast and ovarian cancer syndrome. So for example, if we're looking at an individual and trying to help assess risk for a hereditary cancer syndrome, in this schematic, this individual is a 31-year-old female. And if we're asking about family, we always take a multi-generation family history. If we learn that she has a mother who's had breast cancer at 75, but no other family history of cancer, this is much less concerning for a hereditary predisposition, and really speaks to the fact that this woman's risk for cancer is essentially that of the general population. But in contrast, if we're talking to that woman and we actually learn there are multiple members diagnosed with various combinations of cancers, younger ages of onset, multiple generations affected, this is much more concerning for a hereditary cancer condition. And we do feel that her risk for cancer is higher than that of a woman in the population. And you can see in this schematic that even paternal family history matters. So when we think about breast cancer, sometimes individuals may feel that we only need to worry about it if it's on the maternal side. But for every gene that we have two copies of it, and we get one copy of every gene from our mother and one copy from our father. So again, men can carry these hereditary predisposition risk factors. They may not always express it in the same way. They may not know they have it, but both sides of the family will always matter when talking about a family history assessment. And when we think about hereditary risk for breast and ovarian cancer, it all really started with two genes called the breast cancer genes, or some people refer to them as the BRCA1 and BRCA2 genes. These two genes were actually discovered in the mid-90s. So BRCA1 was discovered in 1994, BRCA2 was discovered in 1995, and we've had clinical testing for these two genes since then. Clinical testing basically involves looking for a mutation somewhere within these two genes. We all have these genes. These genes are actually very helpful in helping prevent cancer, if you will. So we want them, but the trick is we also want them working. And so it's really for individuals who have a mutation or a DNA change in one of these genes that have an increased risk for cancer. And while the BRCA genes and testing for mutations in these genes have been around since the 90s, really awareness around these genes and the potential risks associated with these genes didn't really take off until the later 2000s. And in 2013, Angelina Jolie, a very public figure in the US, put these genes in a spotlight. And she may be one of the most famous people known to carry a hereditary risk due to a BRCA1 mutation. But because of her willingness to be outspoken regarding her results and her willingness to be outspoken about the preventative measures that she took, which included a bilateral mastectomy for breast cancer risk reduction and removing her ovaries and fallopian tubes for ovarian cancer risk reduction, she really put a spotlight on these two genes and started to dispel the myth that there was nothing you could do about it if you had a mutation in one of these genes. And so from that, testing started to take off, to be honest, and people became more concerned regarding personal and family histories. There's a term that's used called the Angelina Jolie effect, where there was an increase in referrals for assessment to see whether individuals really needed this testing or not. But that also led to more awareness regarding the genes and the risks of cancers associated with these two genes. So by far for women, the primary risks associated with a mutation in one of these genes is breast and ovarian cancer. But we also know there's a slight increased risk for other cancers such as pancreatic, melanoma, and then for men, a higher risk for prostate and male breast cancers. So again, it started to really change the landscape of what our knowledge was regarding hereditary cancer risk. And that landscape continued to change over time. So again, while it started with BRCA analysis, we actually started to discover new genes over time. So in 2012, there was an expanded hereditary cancer panel that was launched by one of the laboratories in the US. At that time, the panels and other laboratories, not all laboratories were able to pursue or offer testing for BRCA1 and BRCA2. It wasn't until 2013 where there was a Supreme Court ruling in the US that claimed that human genes cannot be patented. And so around that time was when other labs were beginning to offer gene panels that included BRCA1 and BRCA2, but also included some of these other genes that had then been discovered. As there were more labs offering testing, that brought the price down. It also allowed for advances in technology to actually look at these genes in new and different ways. And essentially, when the costs came down, insurers, at least in the United States, began covering more individuals for testing. And now there's just been an explosion of hereditary cancer gene panel testing through medical practices like ourselves with Genome Medical working with different laboratories, but also through an explosion of direct-to-consumer tests. And so as these new genes were discovered, more people were being tested for hereditary cancer panels. The cost was coming down. It also became apparent that there were many overlapping cancer risks between different genes. And so really today, and at least in the USA, gene panel testing is standard. It's no longer adequate to only look at the BRCA1 and BRCA2 genes when we're concerned about a hereditary predisposition to breast and ovarian cancer. And so this slide and pie chart really represents the genes that are typically seen for individuals who have a hereditary predisposition to breast cancer. So you can see that by far, BRCA1 and BRCA2 are still our big players. So when an individual has a mutation increasing the risk for breast cancer, it's usually going to be in either BRCA1 or BRCA2. But when you look at the remainder of this pie, all of those individual pie slices, when added together, make up a significant portion of the hereditary breast cancer genes. And so we now offer a panel as standard of care because we would hate to miss a mutation that could be acted on simply because we don't look. And as you can see, some of the lifetime risks for breast cancer actually are very close to the lifetime risks for BRCA. And so if we were to look at the gene PALB2, that lifetime risk for breast cancer is somewhere between 33 to 58%, depending on what research study is looked at. But that risk in comparison to BRCA1 and BRCA2, those lifetime risks are somewhere between 60 to 85%, depending on what study you look at. All of that is in comparison to a general population risk for sporadic breast cancer of about 12%. So the risk is significantly increased enough to where we want to do something different for women who have a higher risk. And then likewise, this pie chart represents the different genes that can be associated with a higher risk for ovarian cancer if a woman has a mutation in one of these genes. Once again, BRCA1 and BRCA2 are your big players. So if it's hereditary, it's likely one of those genes, but we wouldn't not look at the other genes because again, we wouldn't want to miss something that actually could be acted on to help reduce ovarian cancer risk. So here you can see genes associated with increased risk for ovarian cancer and the lifetime risk for ovarian cancer is associated with each gene. And in comparison, the general population risk for women for ovarian cancer over their lifetime is about 1.5%. And so these risks are increased enough to where we do make different medical recommendations for women with the mutation. So I want to come back to this slide for a moment because when we do think about genetic testing to help identify individuals with a hereditary predisposition to cancer, sometimes there's some confusion in the different types of genetic tests that are out there. When we do genetic testing, we can do two different types. So one type is actually looking at the genetic makeup of the mutations in the tumor cells. So if basically looking at and testing the red cells in this slide, and we can get some information from those cells, which is very helpful to the treating providers such as medical oncologists, surgical oncologists, to help determine what is the best treatment for this individual based on the genetic makeup of the tumor. And so many times we call that tumor testing or sporadic testing, or somatic testing. Many times those are ordered by the treating providers in order to help best make the treatment decision for that individual. So it's sort of a personalized medicine type of test. But what it doesn't actually tell us is that cancer and the mutations within the cancer, are those inherited? So you could see that we're looking at the red cells, but we're not really getting all the way back to conception, where was there a mutation at the beginning or not? And so somatic testing is very helpful in treatment decisions. It is a genetic test, and Genome Medical can also help facilitate that testing. But it's most often used by the treating providers. And I do want to mention it because it is also an offering that Illumina has made available to employees as well when needed. The difference in genetic testing for hereditary predisposition is really taking a step back all the way to look at the DNA. So what we're trying to decide is, did someone have a mutation when they were born? And so that typically is done with a saliva kit or a blood test that has to be sent to a different laboratory to help determine that. So as a medical practice, we can help facilitate both. Most often the tumor testing is used by the treating providers. The hereditary testing ordered by a company like ours is also sometimes helpful for the treating providers, but they don't always answer the same question, if that makes sense. And with genetic testing for hereditary predisposition, I always mention there's always 3 possible results whenever we look at one gene. And the first is what we call a variant or pathogenic variant that increases the risk for cancer. And so in this case, this is a result that would lead to some sort of medical management change based on the risks associated with mutations that were inherited. Another possible result is a negative test, meaning that the genes on the gene panel were looked at, there was no mutation and no pathogenic mutation identified. And in this case, there are 2 ways to interpret that result. One is a reassuring negative, meaning we believe this negative result, and based on personal and family history, the cancer in the family we believe was sporadic, and/or we're not concerned there's a underlying hereditary risk that's undetectable. The second would be a negative result that's not reassuring. So sometimes we can see family histories. If you think back to the family I showed earlier who had the ovarian, breast, pancreatic in the family, if we had a negative test in that family or individual, we still might be concerned about a hereditary predisposition condition or syndrome that's just not yet been detected, or we might not know the gene involved in that. So currently, we don't know every gene associated with hereditary risk for cancer, but we will learn more over time, similar to the 90s where all we had testing for BRCA1 and BRCA2, and now we have gene panels that we can offer. That's only going to improve with time. But I always like to say that sometimes a negative is not a negative, it's just an uncertain, and that's where the family and personal history really comes into play. And then lastly, when we do genetic testing, there is always a third possible result called a variant of uncertain significance. Variants of uncertain significance are changes that the lab just hasn't seen enough yet to know exactly what they mean. So they do report these, but they also report that it's unknown what the meaning is. But as you can see, it does fall in the blue section of these arrows, meaning that we would not change someone's medical management, and medical management should not be changed based on a variant of uncertain significance. That's where we would fall back to the assessment of the personal and family history. Most labs do track these changes. They actually do mine the data to eventually be able to reclassify these unknowns. When they're able to reclassify it, they'll send us an amended report and we recontact the patient. In hereditary cancer testing, about 90% of variants of unknown significance turn out to be benign, meaning just population variation and nothing we would act on. And that's because while we all have the same genes, we can have slight variations that just make us unique, but don't actually affect the function of the gene. But this is always a possibility whenever we do hereditary genetic testing. So some people ask, why would I do testing? Is there anything I can do about it if I'm positive? And the answer is absolutely yes. So these are clinical tests meant to be used in a clinical way to help reduce risk for cancer. And again, that's our real goal here. And so when we think about proactive measures that can be taken, in general, they either come down to personalized screenings, risk reduction with surgical interventions, or sometimes there are medications that could be offered to help reduce risk as well. So if we think about increased risk for breast cancer, individuals at higher risk in the US can have breast mammograms in addition to breast MRIs every year. We typically start those at earlier ages. They're done more frequently. If we are thinking about a gene that may also increase the risk for colon cancer, colonoscopies can be started earlier, done more frequently, and sometimes with different modalities, with the idea that colon cancer starts as a colon polyp. So if you're removing polyps, that's a means of prevention. Alternatively, there is risk reduction with surgical intervention. So keep in mind that screenings don't always prevent something. So a mammogram doesn't prevent a cancer, MRI does not prevent a cancer, but the idea is a screening would pick it up early is the hope so that it would be more treatable. Whereas surgical intervention, the idea is we're really trying to prevent something from happening to begin with. So one way that high-risk individuals, women, at high risk for breast cancer can take that step is to do bilateral mastectomies with or without reconstruction, which is removing the breast tissue from the body. Alternatively, if a woman's at higher risk for ovarian cancer, removal of the fallopian tubes and ovaries is a means of prevention. And then again, as I mentioned, there are some chemo preventions for breast cancer risk reduction. There are also some for ovarian cancer risk, oral contraception may be prescribed as a way to reduce risk. And then, of course, genetic testing can have implications for family members when there's an identified mutation or pathogenic variant. So in hereditary cancer genes, almost always these mutations are inherited, meaning either from the mother or their father, and this is from generations back. And so we always encourage individuals, particularly when there's a mutation identified, to share that information with their family members because there are actionable steps that can be taken. And so you can see here that for the majority of the genes in hereditary cancer, most of these are what we call dominant, autosomal dominant, meaning that if an individual carries a mutation, there is a 50% risk that that mutation would be passed on to each child and a 50% risk that it would not. The only way to know who else in the family may have a mutation is with testing. And you may hear this term called cascade testing, but that's essentially what it's referring to. So sort of taking that cascade out to help other individuals reduce risk if necessary, or alternatively to learn that they may not have inherited the familial risk and don't need to take proactive measures. Many times we get questions about insurance discrimination regarding genetic results or genetic status. Speaking specifically for the US, there is a federal law called GINA, Genetic Information Non-Discrimination Act, which is really specific to health insurance and employers and is a federal law, so all states have to comply, preventing insurers and employers from discriminating against unaffected individuals regarding their genetic results. It does not include insurers such as life insurance, disability, or long-term care. So different groups have different protections. Right now, we don't have protections for those three groups in the US. And then I will just comment that, of course, in different countries around the world, there may be different laws in place depending on what country you are in, or there potentially might not be a law. And when we're thinking about genetic testing, it is very country specific, given the different health insurers or universal health insurance programs that are out there. But that is something that Genome Medical would be happy to discuss if and when necessary. So when should someone see a genetics professional regarding their personal or family history of cancer? And we touched on this a little bit earlier, just regarding some hallmark features. But in general, we can separate these into kind of three different boxes. There are some age-related red flags. So if there's breast cancer in the family, or if an individual's had breast cancer before age 45 or 45 or younger. Different tumor types, so triple negative breast cancer at or before age 60. If an individual has ovarian cancer, pancreatic cancer, male breast cancer, or even metastatic prostate cancer, those are indications that are now out there where it's a recommendation for that individual to see a genetics professional. And then, of course, the other red flags and hallmark features that we talked about earlier. So as you can imagine, given the worldwide incidence of breast and ovarian cancers we discussed earlier, it's no small feat to try to serve individuals and their family members who may have a hereditary risk, but that doesn't mean we shouldn't try. And we at Genome Medical, in partnership with Illumina, are trying to take on that challenge together, and bring this to you as employees if and when you need it. And so just to touch on Genome Medical a little bit, we are a USA nationwide network of genetic experts that includes genetic counselors, medical geneticists, care coordinators, and then a robust business team. And we provide these genetic services to individuals and family members who may be at higher risk for cancer, breast and ovarian cancers included. But as you can see here, we do also see individuals for other indications. And one of the ways we're trying to help employees is with the Illumina and Genome Medical Genomics Resource Center. And so there are some slight differences whether you're located in the US or if you're ex-US, but these services are really meant to get your genomics and genetics questions answered and or help guide you through any type of genetic process, whether genetic testing or other that we can. And so if you're in the US, some of the services that are available to you at no charge through the Genomics Resource Center include chatting, emailing, or calling a care coordinator, scheduling genetic counseling sessions, providing peer-to-peer support for your healthcare provider, and even helping to facilitate genetic testing. So we can coordinate testing, order testing in any of the 50 states, and work to get self-pay or in insurance coverage, depending on what that test and indication is. If you're outside of the United States, services are still available to you, but primarily through a peer-to-peer support with your healthcare provider. And currently, that's more dictated by the different laws throughout the different countries in the world. But if you are concerned and or interested or just wish to learn more, Genome Medical providers are happy to talk with your provider and can guide your provider through the process within your respective country. So it's also through the Genomics Resource Center landing page. You yourself are also welcome to chat, email, call, and talk with a care coordinator. And so the way to access resources is through the Genome Medical Illumina landing page, which you all have access to. If you are actually located in the US, you would come to the bottom of the page, at which point you would click the Schedule Now button, and it would lead you to the various options available to you. If you're outside of the US, you actually would click the Learn More option, and it will take you to a page where it asks some basic information for a peer-to-peer consultation service. So it's fairly self-explanatory, but our contact information is on the site. So if you have any questions or concerns as you're going through the process, we'd be happy to help. And then, really the whole goal of this, again, trying to reduce cancer incidence, but also cancer mortality, is to work with you and your provider to get the right assessment at the right time. So we want to help educate on genetics and genomics, inform patient care, assess which of you would most benefit from genetic testing services, select the right test, as well as help integrate these back into your care. And so with that, that concludes our webinar, and we are more than happy to take questions. So again, if you have questions, please feel free to enter them in the Q&A box. You can do that anonymously or just enter it with your name. And someone has asked, will the recording of this presentation be available later? I missed some of it. So the answer is yes, we will make this recording available. And we will try to do that through the Resource Center. Are there any other questions? So another question's come in, are only the people with high risk can use genetic counseling? So that's a great question. No, so partly why we have worked together and we've named this the Resource Center is because we want to be a resource for all things genetics and genomics. So you are welcome to use the Resource Center for any question related to genetics and genomics that we can help with. So please feel free to access us. Again, if you're in the US, it would be usually it's starting through the landing page. A care coordinator is actually able to pick that up. Sometimes if it's a logistical question or something like that, they will answer it. But if it needs to be escalated, then you can schedule an appointment with the genetic counselor. Or if it's something that they are just not able to answer, then a genetic counselor would answer that as well. If you're ex-US, it will need to be to your provider. So we are currently not able to provide medical advice to patients outside of the US as a direct medical advice to the patient, but we can work with the provider. Great questions. Any other questions? Okay, well, we want to thank you all for joining today. We really appreciate your time, and we look forward to the continued collaboration in the Resource Center work. But thank you all. Hope you have a great weekend.